Thanks for Dr. Li's invitation. I am Chen Kailing from Fudan University Zhongshan Hospital. My topic today was the contrast-enhanced ultrasound features of hepatitis and normal with active hepatitis tumor. This is a female of 24 years old. Her active component was mild hepatic lesions detected in philosophy examination. No specific medical history was recorded. The laboratory tests showed negative for HPV infection, and the tumor markers such as AFP and CEA was in normal range. On grayscale ultrasound, mild lesions was observed in the liver with a maximum size of 4 cm and clear margin and irregular sample. CDFI showed line blood flow around the lesion with lower resist index. After injection of Sonavil, the lesion was hyper-enhanced rapidly in arterial phase. Stable enhancement was also detected. In post-venous phase, it was also enhanced, and in late phase, part of the lesions was showed slightly washed out. On CMRI, the lesion was mildly hyper-enhancement in arterial phase and relatively hyper-enhancement in the post-venous and delayed phase. They were considered as malignant tumor, while a 3 cm lesion was observed in the cervix. Then the patient underwent PET-CT. The masses in the liver and the cervix were FDG positive. They were considered as metastasis or lymphoma. So, what's the diagnosis? Benign or malignant? Primary or secondary? The MDT suggested ultrasound-guided biopsy should be performed to clarify the hepatic lesion. The result turned out to be inflammatory hepatocellular adenoma. With the unbelievable result, biopsy should be performed again in MDT for another suspicious hepatic lesion, and the pathological diagnosis was the same as before. On that condition, the surgery was for the thoracic masses was put into effect. The post-operative pathological diagnosis was osteoblastoma, and the lesions was untreated in the liver, and they were stable in the 3 years of follow-up. HCA is a kind of rare benign hepatic lesions, and it was highly heterogeneous. According to the WHO classification of hepatic tumors, it was divided into 4 subtypes: inflammatory, HN-alpha inactivated, beta-catenin activated, and unclassified HCA. The HCA are always hepatic with clear margin and regular simple heterogeneous inter-echo and low resist index. On CUS, the overall has impairment subvascular hyper-enhanced and in the arterial phase, and about half the lesions showed washed out in the post-venous and late phase. According to the literature, CMRI was reported to be superior in the diagnosis of HCA than CUS. The lesions showed hyper-enhancement heterogeneously in the arterial phase, and partly hyper-enhancement in the post-venous and late phase. And on PET-CT, the IHCA and HN-alpha inactivated HCA might be FDG positive. Therefore, ultrasound-guided biopsy is needed when necessary. That's all. Thanks for attention.
Thanks, Dr. Chen Kailing, for your presentation. Now we would like to have Dr. Chen Ling to comment, please.
Dr. Chen Kailing, thanks for your brilliant presentation. The simultaneous occurrence of intrahepatic and extrahepatic tumors brings confusion to the diagnosis, but the liver lesion was determined as benign by CUS and subsequently proved as hepatocellular adenoma by 2 times of biopsy. So I have a question. Could you please briefly summarize the key points of differential diagnosis of benign liver lesions, such as adenoma, hemangioma, and FNH on ultrasound, including CUS?
Thank you. Next question. Hepatocellular adenoma, in the literature, it was difficult to distinguish from FNH, but in the database in our center, it was difficult to distinguish from HCC. For example, the HCA presented as overall hyperenhancement in arterial phase, while hepatoma and FNH was different from the enhancement pattern from HCA. And in the Portman's and the late phase, FNH and hematoma were always hyperenhancement or ASO enhancement. But HCA, in the database of our center, half of the HCA was showed washed out in the late phase. It's more similar to HCC. Thank you.
Thank you very much.